Well, I was real fortunate, Josh. I got here in 2011, so learning about the Affordable Care Act and what it was going to do to hospitals was kind of a interesting experience. I think we were all going, the healthcare community was kind of going through this all at the same time. So the initial changes that happened, I think, really started here in Kentucky with the expansion of our Medicaid program. And that has some very unique effects, both positive and negative for the organization. Part of the negative effects was our Medicaid patients, that population, the government payers, really don't pay very well. So that had an impact on our what we call our payer mix, and that's the number of government pay patients we have versus number of private pay that we have or self-pay that come in through our doors. As the government pay goes up, our margin tends to get smaller. So that had a little bit of an impact. So you saw it on both sides. Positively, patients, more people were covered through Medicaid, and negatively, well, we weren't making the margins we were making that we would expected there to the number of patients that we were seeing. So that's one, I think, big change. And then the other one was probably had to do with quality. The government asked more and more of us from a quality perspective. They were looking to look at things for like value, we call it value-based purchasing, for make sure we're paying for quality from a government perspective. And I think that drove things very well. I really appreciated that aspect of the Affordable Care Act. We had other things called the hospital-acquired conditions. That is another piece of that to drive that quality. And the lower infection rates you had, the lower falls that you had in hospitals, it eliminated your possibility of getting any penalties as a result of that. So I think that was a pretty good aspect as well. So those two were good on driving quality, and I have to say that was positive throughout. We knew that more people were going to be covered. That was part of the plan itself under the Affordable Care Act to give more people access to insurance. But there were some other aspects I think they're going to affect us down the road. So I'll leave it at that and see what other questions you may have around that. Well, I talked about the Medicaid expansion. That came in about the end of 2012. And what that did was, across the state of Kentucky, it added about another 400,000 Medicaid beneficiaries. And that in and of itself, you think, well, that sounds pretty good because that means more people getting access. Well, that's true, but the spigot's kind of small. We have, on the negative side, we had providers out there that weren't going to take Medicaid. As I indicated earlier, Medicaid's not a real great payer. Let me give you an example. I always like to use this donut analogy. So if you're going to build a donut, you're going to make a donut. You put all the flour and the eggs and the milk and the yeast and all the things you need to have for that donut. And it costs you $1 to make that donut. But you start selling that donut for 80 cents. How quickly do you start losing money? Well, first donut you sell. I just explained to you what Medicaid's all about for us. It's based on percentage of cost. So if it costs me $1 to give somebody care, and I'm only getting reimbursed at 80 cents on that $1, I start losing money really, really quickly. And if you add more donuts, if you're selling more and more donuts, which is exactly what was happening, you lose more and more money based on the cost that you were having. So that was one challenge for us. Again, positively, it was good that more people got coverage. Downside, hospitals suffered throughout the state. And when I came in, I'm going to be the chair of the Kentucky Hospital Association this summer. When I started with the Kentucky Hospital Association, we had 131 hospitals. Today we have 126. Well, what happened to the other 5? Well, Affordable Care Act made some major impacts on them because you still had to take care of the patients, but you weren't getting paid as much, and some of the hospitals just couldn't survive on those margins. So that is a challenge for us. Immediately saw some, in our emergency department, we had physicians that, well, let me talk about physicians. Physicians around the area just couldn't handle the load of all those Medicaid patients, or they couldn't handle the payer mix. So they opted not to see Medicaid. Now, I can't do that as a governmental hospital. I see all patients. But private physicians can opt not to do that. For instance, we had a couple of classifications of physicians out there, specialists, that wouldn't see any Medicaid at all. So they might have to travel 4 or 5 counties away to find somebody that would accept that particular care, type of specialty. A lot of those patients, even on the primary care side, ended up in my emergency department. So from 2012 on, it was like we flipped a switch. I used to see about 12 to 1,300 patients in my emergency department, and then all of a sudden jumped up to 1,700 and 1,800. Well, what happened? Well, the Medicaid expansion. We typically saw in the emergency department about 200 Medicaid patients. That number really crested at about 650 to 700. So the number's really grown exponentially, and that's probably not the right place for all of our Medicaid patients to go. They really need to have a private primary care physician. And emergency departments don't do that. That's not what they provide. They're supposed to be there for emergency care. But we saw them nonetheless, and that was a couple of the immediate things that we saw happen out there. Well, I think the American Health Care Act is designed to do a couple of things. One, we know there's a lot of partisan politics that are going on between Republicans and Democrats, and the challenge is, do you repeal and replace? And we've all heard, well, are they just going to wipe it out altogether and start out with something new? Are there aspects of it that are pretty good that we'd like to keep? And I didn't touch on that when you asked me the first question. Part of the positive things with the current Affordable Care Act policy is that we're covering children up to the age 26, so they can stay on their parents' policy. Once again, pretty good. Covering more Americans, and the expansion covered about another 20 million Americans across the board. About 7% of our population, when you think the United States has about 300 million people. So that was key. And I think under the American Health Care Act, they recognize those are two good things. Try to have that policy putting coverage up to age 26. Another positive thing that the Affordable Care Act changed was that it had covered those that had pre-existing conditions. It made it difficult if you had a pre-existing condition for whatever it may be. Maybe you had a heart attack, or maybe you were born with some challenged a child that was going to have a lot of healthcare bills up and throughout their entire life. You could be denied healthcare. Well, under Affordable Care, that couldn't happen. Insurance companies could not selectively not take that individual. So I think those two aspects, the current policy is looking at saying, yeah, we want to keep that. Those are good things for the American public. We want to hang on to that. The more challenging piece is, where do you go from there? We know that the costs are skyrocketing. We know that there are insurers out there that are having problems trying to maintain their premiums, trying to maintain their margins as well. And what's happened out of that, in places like Arizona, for instance, their premiums have gone up 100 to 118% of what they used to be. I looked this morning because I knew this would be a good question for you, but about 21% across the board is how much premiums have started to rise in the United States just for 2017. Pretty high. I mean, so you're paying a fifth more than what you had been paying previously. That creates some challenges, and we just couldn't continue to rise at that level. Now, under the current plan, there's going to be they're looking at a deficit cut of a Congressional Budget Office said that the current plan, or the proposed plan, would reduce our federal deficit by about 328 million, I believe. Billion. That was a B. Those are some large numbers out there. And that's a good thing. I mean, that's certainly a good thing. But the downside, less people are going to be covered. Coverage is going to be about 14 million people less proposed right now for 2018. That has people alarmed, because you can't imagine taking people off. But that's kind of a misnomer. What's actually happening is what their Congressional Budget Office said was that, yeah, it'd be 14 million people, but that's by choice. They would choose not to take the health care plan. Why? Well, they're trying to take out the individual mandate. As part of the Affordable Care Act, they had an individual mandate that if you, as a young 21-year-old, for instance, did not have health care, and you didn't have it throughout the year, you could actually be penalized when you had your taxes filled out for the year. For instance, this year, the individual would pay about $695. A family would pay a penalty of $2,085, or 2.5% of whatever your household income was. So whichever's greater. So I'm giving you the smaller numbers, but it could be much higher than that depending upon what you made. The Affordable Health Care Act is supposed to do away with that, so there's no more penalty. So if you're healthy and you don't think you need health care or health insurance, you can have your own choice to do that. And if you opt not to take it, you're going to be one of those 14 million making the choice of saying, well, I don't need this right now. Healthcare is, we know healthcare exponentially grows and people need it more as the older they get. So when you get in your 40s and 50s and 60s and 70s, there's quotes out there that 95% or 90% of the healthcare that you're going to need in your lifetime is probably in the last year of your life. It gets very expensive. Some other things that are going to be happening under this particular plan is a reduction not only of the individual mandate, but also of the employer mandate. There was a statute that said basically if you had less than 50 employees, you could opt not to offer insurance and turn them over to the marketplace. And this marketplace was put out throughout the United States, and you probably heard about them. You had a bronze plan, and you had a silver plan, and you had a gold plan. Well, it became kind of untenable, and I'll tell you why. It was nice to have insurance, it was nice to be offered, and the premiums were kind of sort of low. The problem was the deductibles were out of control. So let me give you an example. Here in the Murray Calloway area, the average family makes about $40,000. That's not a bad family. I'm sorry, I got to back up. It's about $30,000. That's what the average family will bring home in a year. The current bronze plan deductible across the United States is averaging about $6,000 right now. So let's say you needed a surgery, you had to pay the first $6,000 of that. That's all. Basically what happened was the insurers or the marketplace shifted that on the individual. Yes, you still had insurance, and we could check that block, but the average family in Calloway County does not have a $6,000 disposable income to pay for it. So what happened in my area, for instance, at our hospital, we saw bad debt initially go down. Now it's starting to rise again because people still need health care. They just can't pay those deductibles, or they still need to get the health care and they get put on a payment plan over to hospital. So instead of being a hospital, I'm starting to turn into a bank. So that's going to change things just a little bit with that employer mandate or the individual mandates that are out there or the marketplace. Hopefully we got to streamline those premiums and streamline the deductibles so it's affordable again. So kind of a misnomer saying affordable care when it's not affordable because you just can't pay for it. Premiums are good, but still there's some difficulty out there. Another aspect which I thought was kind of interesting, I talked to you about how our ages are going to change. I mean, as you get older, you're going to need more and more health care. The tax credits that the Affordable Care Act offered were all geared toward your salary, whatever your salary happened to be. And you would get tax credit for that, so you could buy into those marketplace plans. The difference now is they're going to do it by age under this current plan. And so if you're 30 or 40 or 50 or 60, you get higher credits that can come for you, so you can purchase that health care for yourself. And obviously, as older you get, the more they're going to charge. And then another challenge, I think this is going to be something that's going to be untenable by our American public, is they're going to allow the insurers can pay up to or can charge up to 5 times more for a premium from a younger person to an older person. What does that mean? Well, under the Affordable Care Act, they were allowed 3 times. So let's say a 30-year-old was paying $200 a month. A 60-year-old could be paying as much as 3 times that would be $600 a month. Could you imagine changing that now to 5 times, which would take it to $1,000 a month? Again, remember, the older you get, the more care you need. So do you have a choice to pay or not pay for health care? Your choice begins to be limited a little bit. So I think that's going to be somewhat of a challenge as we look forward, that the older folks will say, we don't like this, that mandate's in there. And it might change, but that is under the current statute that it would be 5 times rather than 3 times as much as a younger person.
And our community in general.
Well, I think the changes as they currently are going to impact us for a couple of things. One, they're going to impact us from the standpoint of people going to make choices. Right now, when people get sick, because of the current economy and the current way healthcare is, it used to be you just reach for the telephone. You reach for your cell phone to make that appointment. Now what happens is you reach for your wallet and say, can I afford this? Maybe I shouldn't get this surgery now. I'm going to put it off a little bit later. And what I've even seen at our hospitals is something called our case mix index has risen over the last 4 or 5 years. Why do you think that is? Well, the reason it's happening is people are waiting longer to go in to get the care that they need to get. They're delaying their care. Even health insurers will say over the last 4 or 5 years, because they're I won't call it discriminating, but they're being a little bit more challenging of the physicians to go, well, I'm sorry, Mr. Smith's not sick enough. We're not going to put them in a hospital. Try some more outpatient care. Because inpatient care is a lot more expensive than outpatient care. So you try this regimen, this regimen, this regimen, we'll go with that first, and then if those turn out okay, then or those don't do any good, then we'll allow you to admit this person for the hospital. So I think that's going to be something that's not favorable. In my mind, I'd rather have people coming in when they're less sick, so we can treat them before they get really bad sick. And I've seen that through the numbers. I mean, it's starting to play its way out. So I think that's going to be a challenge for us. What is it that we could do, or what things that I might change for the plan? One, the premiums have got to be affordable. That's the first aspect. And 2, our deductibles have got to be lower. As I said, there aren't many people in Callaway County that can strike, just on the bronze plan, the lowest level plan, $6,000 to cover their own health care. And that's about any surgery you had over Murray Callaway now, whether it's a knee replacement or something else, it's going to be $4,000, $5,000, $6,000 or more. You've got to pay that first $6,000. That's on you. So the burden now, what we've done is just shifted on the families. I just don't think that's fair. Those deductibles are going to have to come down, and we shouldn't allow our health insurance companies to do that. There needs to be a cap of some sort to help those lower income families, because as I said, that's just untenable. And then last but not least, having insurance for everybody is very key. You can't open the spigot too wide, or you can't take away or make the hospitals pay for these, because our margins are already suffering. It used to be, for instance, when I talk about margin, that's the money I have left over to pay for things like buildings and new equipment, and that's important. For the standard of care for our community, we need to have the best equipment we can have. We need to have buildings that are functional. We need to open up new services if we can. But if I can't afford it, how far must you travel to go get the same thing that I can potentially provide for you here? So those shrinking margins, I think, are going to impact hospitals, which I already indicated they have. We've closed 5. I'm fortunate to be a survivor out there, but there are many hospitals that are on the edge. Throughout the United States in the last 5 years, 80 hospitals have closed. Thousands and thousands of jobs have been lost as a result, not just in those areas, but a lot of downsizing. Yesterday, here in our local area, our Baptist hospital located in Paducah, and the Baptist system, 8-hospital system, is going to cut about 275, 280 people. 30 of them are coming out of the hospital here in just to our north. Transitional care unit, they're going to close down because they just can't afford it. So a lot of those, even the bigger hospital systems, and I'm a single hospital system versus an 8-hospital system, if they have to cut, well, it's going to have to cut us too. Even going back to 2012, I laid off 35 people. Well, actually, I laid off 28 people and another 25 from our geriatric behavioral health unit. So the margins that we have are getting tighter and tighter and tighter. You can't pass that through to the hospitals. I think if you're going to do it, if you're going to increase care for all, then, and I'm not a big fan of raising taxes, but I think you have to tax the public, or you have to find more money out of the federal government to pay for it. And that's going to be a huge challenge. And right now, just look at it in the state, 1 out of every 4 people that you run into here in the state right now are on Medicaid. That's the statistic. It's an amazing statistic. When I first started this, it was 1 out of every 6. So 1.2 million in our state are on a Medicaid program. It's expensive. And we do have to take care of our lower income people. But there's going to have to be some offsets, and it can't go to the hospitals. It's got to be somewhere out of somebody else's budgets, as opposed to, just take it out of the hospitals, or they won't survive. And if hospitals go away, how far will patients have to go to get the care that they need to get?